So PRRT is a treatment of which the cornerstone is based on the use of radioactivity that will go through a specific radiopharmaceutical directly into the cancer cells. And because it's working with radioactivity, one might ask, is this not dangerous? Well, there we have a very clear answer. We know from follow-up that has been performed in patients that have been treated for decades long, and also from very well performed so-called prospective clinical trials where the data of the patient is followed from the start until the end, that this treatment is not dangerous. Patients do well, the disease is controlled better than with other treatments, quality of life is better than with other treatments, and symptoms are controlled better than with other treatments. The patients have in a very vast majority no side effects of lutetium-based PRRT radiopharmaceuticals. There is one very rare side effect that is the most dreaded one of PRRT, which is a difficulty in blood regeneration that can occur in a very tiny fraction of patients. Depending on the studies, this is between 1 to 2% or 4%, depending on the specific trial that has been performed. And this is a late problem, so it on average happens 3 to 4 years after the start of the PRRT, and many patients that have this very rare side effect would not be able to reach the time point without the PRRT. But in the vast majority of patients, the PRRT is very well tolerated and there are no long-term side effects. So the answer to this question is very clear. No, the radioactivity is not dangerous. It will do something very beneficial for the patient. And if one respects the radiation protection measures, then it will also be safe for the people around the patient. Not all patients that have a NEN, a neuroendocrine neoplasia, will be eligible for PRRT treatment. There are two different main types of tumors within the NEN family, the so-called neuroendocrine tumors, which are typically slower growing, less aggressive. They will divide on a slower pace than the other type, the so-called neuroendocrine carcinomas, which have cells that divide quite rapidly and that will grow fast. And this latter type, the so-called neuroendocrine carcinomas, or also called NECs in an acronym, there, the data that we currently have, the scientific data, is not that good, and the current way of delivering PRRT with lutetium-177-based radiopharmaceuticals does not work well. And those NECs can be also rare tumors, but for instance, in the lungs, one type of neuroendocrine carcinoma is a so-called small cell lung cancer, which is actually by far the most prevalent type of neuroendocrine neoplasia. And in these small cells, we know that the current type does not work well. And so scientifically speaking, there's no data to back this up. Medically, it's not a good idea to treat these patients with PRRT. And so, of course, it's not reimbursed also. So we do have some patients that have subtypes of NENs where PRRT is not a good option, and then it's not reimbursed. Globally speaking, the main barriers that prevent NET patients from having PRRT treatment are infrastructure, access to trained personnel, and finally reimbursement of the radiopharmaceutical. So for the infrastructure, depending on the national legislation of the country, patients have to be hospitalized for a certain time in specific rooms that are shielding for emitted radiation, and that also collect the waste and the excreta from the patient. We need, of course, nuclear medicine physicians that are trained to do these therapies, and that might not be the case in every country. Some countries have nuclear medicine physicians that focus more on imaging and that have lack experience in treating patients, and NET patients in particular. But it's not only nuclear medicine physicians we need. We also need technologists, we need nurses, we need physicists, we need radiopharmacists. So we need an entire ecosystem of people that are trained and that are capable of performing the therapy in a good way. There is a general reimbursement provided by the national healthcare system, or it can be that the reimbursement is offered by certain private insurances. This will be different from country to country, and some countries might have a very large type of reimbursement where many different scenarios of patients are covered, and in other countries it might be that some specific cancer types within the NET family will not be reimbursed. So that depends country by country.